Good afternoon, friends. It's Friday afternoon, and we are back with one another episode of our Forefront of Future Frontiers, the medical webinar series, which we started in May 2020. And today we are in episode number 64 and the 11th series. This is usually what we do is it's a theme-based webinar. We take a theme and then try to explore different topics under that theme. And the current theme is how we can generate evidence to influence practice. So that is the theme we are working on. And last week we actually talked about how evidence can influence the thinking about the specialty itself. We had a nephrologist sharing her experiences and her personal journey with evidence-based medicine. So today we have one nice talk on how evidence can influence community of practice. Actually, this is a very beautiful term, this community of practice, which comes from the social learning theory. A big group of people who show concern or passion for something which they share, and usually they share their best practices, experiences, evidence among themselves, so that everybody is influenced by how things go. So that's the origin of this term. It comes from the social learning theory, and it became very popular in the Silicon Valley before it actually descended into medicine and education parlance. There are two things we have. One is community of practice. The other one is practice as usual. Practice as usual is what we keep doing. But when we get into community of practice, there is enough evidence to show that it actually influences the culture of the organization. So that is what a brief intro about this topic I thought. And without much ado, I would request Professor Kotur, our Dean, to welcome the speaker. Over to you, sir.
Very good afternoon to the resource person, Dr. Nishad, and all the participants who are here. I am indeed honored to invite you all on this FFF platform on behalf of our management, on behalf of Honorable Chancellor and the esteemed Board of Management and the University at large. And today's topic, Dr. Mahalakshmi gave an introduction. Now, one thing you have to realize, generating evidence is not only enough, but it has to be influence the person and the user. Then only the outcome can be utilized. That is one thing. I was recollecting a little bit inclined towards evidence-based medicine myself. I was just giving a thought. See, when the evidence-based medicine was advocated way back in after 1991, 92 from McMaster University, that time the barriers were quoted, where of course the faculty barrier, senior faculty barrier was the main thing. The resources for the practice, those are the other things, and those were slowly. It took some time to overcome. Then of course now there is no looking back. It has become a new accepted paradigm, evidence-based practice. Now, when they were in line with that, when evidence-based public health was advocated, and after 95, 96, then they rigorously tested interventions were attempted to be applied with the community. Of course, with the benefit of the community, for benefit of the markers, of the health markers, or whatever you say, overall benefit of the mankind. Those are all broad terms. When it was attempted, even though those interventions were rigorously tested and had a reasonably good scientific basis, the barrier was a different one. So community of practice, Mahalakshmi described just now, a group of people who will share a common vision. We should have a similar thinking, similar commitment, a similar expertise, similar competence. Then only it will work out. This aspect of the evidence-based public health was literally a kind of thing. It was, I rather use the word, it was neglected. Only after realizing that, when these things were introduced, the community-based orders or community-based these things, And now also, if you say, especially apply the community-based practice for especially for the addressing the mental health of the community or something, you still find that there are no authentic evidences in support of those interventions to the community. So this is where we stand, and So one thing we all know that the necessity is the mother of the invention. So we need to identify uh, the critical mass or the community leaders to ascertain or identify their needs. Then once those are there, you take their opinions and try to incorporate them into this practice what you intend to do, put on the community. Then they will feel comfortable. They will not pose gory barriers. They will feel that they are also owners of that whatever practice. Then we can have a definite outcome. These are some random thoughts that came to my mind. We have an expert, Dr. Nishad Plakal. No, he certainly must, when he has trying to address this issue, he must have certainly gone into the depth of that and the issues related to that. Wonderful. We will look forward to have his wonderful thoughts on this occasion. And I take this opportunity once again of welcoming you all, including Dr. Nishad, to this 64th episode of our prestigious Triple F webinar of Ayurvedic Medical College, Pondicherry. Thank you. Over to you.
Thank you.
Thank you. Thank you, sir. May I request Dr. Vishnupat sir to introduce the speaker?
Yeah, good afternoon to everybody. On behalf of our management, Dean, HP, and all your staff, I welcome Dr. Nishad Plakkal, who is Associate Professor of Neonatology. He's a young, energetic neonatologist. He completed his undergraduate from Trichur Medical College, later MD from PGI Chandigarh. He spent about 4 years in Canada doing his residency program and fellowship program in neonatology. And his wife is also our student, so I think it is like coming to father-in-law's place. So he joined us. And we were working together in the Jipman neonatology. And he's a simple person, but hardworking and sincere. And he has got several publications, and he is very meticulous in his work. He has published nearly 38 papers and about 22 book chapters, edited 2 books, and he's also a reviewer for some of these journals. His main area of interest is hypoxic ischemic encephalopathy and quality improvement. I think in different, quite a few work have been done in these areas, and he has got several awards. Best thesis award for his MD DM students thesis by IJP, and best scientific paper award from Diploma Scientific Society. He is guiding MD pediatric students, DM neonatology students, and we also have BSc and MSc nursing students who come for their project work. So we have co-guide them and also guiding PhD students. And he's one of the lead persons for neonatal resuscitation program by the National Neonatology Forum and Indian Academy of Pediatrics. And I'm sure that he will enlighten all of us in by his talk. So welcome you, Nishad. So back to Dr. Malakshmi.
Thank you, sir. Before we pass on to Dr. Nisha, we'd like to tell the audience that this program is being streamed live on YouTube, and we are also recording it for posterior academic use. I request all participants to keep themselves muted so that the audio quality is good for everyone. And please post your questions to the speaker in the chat box. With this housekeeping announcements, it's back to Dr. Nisha for your talk. Over to you, sir.
Ma'am, can you allow me to share?
Yeah. Yes. 1 minute. I have made you the presenter, so you should be able to share.
Okay. So, thank you, ma'am, Dr. Bed, Dr. Kotur, and others for inviting me. This is a very interesting topic and one that very often we struggle with. How do we influence our own community of practice? But before we talk about it, I will take especially the what this community of practice stands for. So we'll talk first a little bit about community of practice. I have no conflicts of interest to disclose. So what is this community of practice? So we all work in communities. This is not a community in the general sense of the word, not the community that we are serving, but they are also a community. But community of practice is, this is what Wikipedia has to say about it, a group of people who share a concern or a passion for something they do and learn how to do it better as they interact regularly. So essentially, you can think of it as your team. This team can be in different settings. This term actually came about for a few decades ago. And when I think about learning as a community, one easy way to figure it out is when you think back and think back to the days when you were a resident. Like at least for me, when I was a resident. Some of you are still residents, and some of you may be even getting there. But when you are a junior resident, who do you learn from? So if I have to be honest, I should say that I learned for the most part from my senior junior residents and from the senior residents in pediatrics. The consultants do teach in PGI, but less frequently. They are there to moderate discussions. They provide the structure. They are important, no doubt. But you don't learn, for example, procedures from them. So you don't learn how to put a chest tube from your consultant. You learn it from your senior resident or your senior JR. You generally learn most of your patient management from the seniors, from seeing what they do. You read up and follow protocols on your own also. You also learn from consultants. It's not that you don't. And you learn from some things you do learn from nurses and other staff that are working with you. So the whole place you can think of as a community, but most of the learning is actually from your peers. And this is where the concept actually came about also. The phrase was first used by Etienne Wenger and his colleague Jean Lav. And they were actually studying tailor apprentices in Africa. And what they found is that most of the learning was not from the boss, the person who was the mentor, but most of the time the apprentices learned from among each other. So this is because they are like a community. They are very close to each other. They spend a lot of time together. They have a common interest, a shared interest. And in the process of pursuing that shared interest, they learn from each other and they help each other's personal and professional development. So this is what the community of practice means. You share a common, what is called a domain or an area of common interest. You may have common goals. And while you are personally and professionally develop and also contribute to that community. So the idea is that learning is an inherently social process and it cannot be separated from the context in which it happens. So, and this we know in practice that learning this way is much more effective and much more interesting to residents. So most of us as undergraduates would have fallen asleep at least in a couple of lectures during MBBS days. But nobody falls asleep while working as an intern, because it's much more immersive, experiential learning. You are actually interested in doing it. You are learning by doing. So this is of course exciting to the students. I mean, it's much more exciting than the theory classes and even the practical classes. Actually doing work, even if it is running around collecting samples or just attending normal deliveries or conducting normal deliveries. So this is still very exciting because you are doing it and learning directly while doing it. So this is where the concept comes in. It is not exactly apprenticeship we are talking about, but because in apprenticeship there is a very strict hierarchy. There is a mentor and a mentee, a teacher and a student, a very strict hierarchy. But here we are talking about more about teams. We can still have leaders and all that, but this is more like the higher one among equals. So nowadays, that is how we work in clinical medicine also. But how does this translate into research? That's what we are going to look at. So, like I said, this is about learning as social participation. When we talk about these communities of practice, these may not be groups that are deliberately created. Some evolve naturally. For example, you start working on one particular area in research. Others who are interested in it may approach you to collaborate in research, and you may start working with them. Then others join you, and it becomes an informal group. Sometimes they are formal groups that are created deliberately. Like, for example, I'm part of a group that is looking into the effects of COVID for NNF. That was created by NNF. We are looking at the effect on residents and other, pediatricians and all that. But that was created deliberately. And we also share some common goals. And in the process of doing this research, we are also learning ourselves. So that is also a community of practice. And like I said, it helps us develop personally and professionally. And this happens everywhere. It's not just at work or research. Your football team, you can think of as a community of practice, or a band, or a church, or the religious group. At school, you have your own small communities of practice. You may have shared interests, and you may have small groups that pursue it together. So they are actually everywhere, but we are particularly going to talk about translating evidence to practice by influencing these communities. So, in other words, research that can sway your particular community of practice. How do you generate that evidence, and how do you get your own team to be interested in it? So this is very important and it's an important area nowadays where there is a fairly big gap between research and practice. And those of you who are researchers already would be familiar with the Cochrane logo and what it stands for. I work in neonatology, so this is also pretty close to our hearts, because the Cochrane logo actually stands for a forest plot. And this particular forest plot is a forest plot of an old review, a systematic review and meta-analysis of antenatal steroids. Now, the problem with antenatal steroids was that there was excellent evidence that antenatal steroids reduced neonatal mortality from multiple randomized control trials. But it never translated into practice. A decade and a half, people did not act on that evidence. People were doing individual studies, but not many people read it, and even the people who read it don't often translate it into their practice. So tens of thousands of neonates would have probably died unnecessarily during that period, when we already had evidence that antenatal corticosteroids improve lung maturity in neonates and can improve survival of preterm neonates. So this was one of the earlier, not the first, but one of the earlier Cochrane reviews. And Cochrane actually adopted it as their logo, because that particular forest plot, at that time, there were 7 RCTs. As you can see, there are 7 lines and 1 diamond at the bottom. And the diamond is far away from the central line, indicating that this is an effective intervention. So that Cochrane review was actually a game changer. It actually influenced most institutions to switch to using antenatal corticosteroids in women who are at risk of delivering preterm babies. And of course, it has saved countless lives after that in both developed and developing countries. Even recently, WHO sponsored a large randomized control trial came out with the centers in India and other places, just reaffirming what we know, that it actually saves lives, because there was some question about its effectiveness in developing countries. They had to do one more randomized control trial. And now I think we know for sure that this works. So this is an example of how influence practice. But the point here is also that there was a large delay in implementation of this evidence in practice. So is there any other way, or are there other ways in which we actually can take the team along and they can learn while they're doing the research itself and can be convinced about best practices and what they can do to improve, outcomes for their own patients. And this is not just for clinical medicine, really. It may not be patients, it may be a process. For example, people working in biochemistry might be trying to figure out how better to do one particular process and how to improve that. So I'm not talking entirely about clinical medicine, but I'm a clinician. So for the most part, I may be talking about clinical outcomes. But this applies across all fields. It's not just, obviously, as Madam was saying, this phrase community of practice was in vogue in business and software industry before we started looking at it. So obviously it is it works across multiple areas. So this, like we said, this is a major issue. Let's say we have a lot of omics studies, proteomics, genomics, metabolomics, and all that, and showing evidence of benefit for some intervention. How do you translate it into actual community intervention? So that actually benefits the community. So this is like a bench to bedside issue, and that has been bugging us for some time now. And this is how traditionally we have been thinking about it, evidence-based medicine. This is one of the models, not just the model. So the idea is that we locate the evidence, we evaluate the evidence, we assemble the evidence, and then that informs our clinical decisions. But this is easier said than done. Many practitioners don't go through the hassle of doing all this. Even when someone like Cochrane, the Cochrane collaboration, has actually done all this, the first 3 steps for you, it still does not always inform our decisions, right? They have actually provided the summary in a capsule form, and we just need to look at the conclusions to some extent. Of course, it's better if we can read the whole thing, but at least if we take the message and implement it in our work, that would be good. But that doesn't always happen. And that's partly a problem with the current state of research. So we are going to look at, I'm going to talk only about a few ways in which you can influence your community of practice. And these are not the only ways to do it, but these provide some important lessons about how learning can be better for teams with participation. So the first thing, and that's somewhat close to our heart, because in our unit, there is, at any given time, usually there is one or the other QI project going on. That's quality improvement. So quality improvement initiatives are, traditionally we had trouble publishing them because they weren't even considered research. But nowadays there are even dedicated journals for it, and there is increased awareness that these are an important, clinically relevant form of research. So, and they are, usually they tend to benefit the patients much more directly and in a larger scale than, let's say, a randomized controlled trial of a drug. The other thing I'm going to talk about is participatory action research. I'm not really an expert in qualitative research methodology. And in fact, I have only just a month ago submitted my first qualitative research proposal to a funding agency. So, but I'm learning it. And this particular area of qualitative research happens to be very fascinating and directly impacts the community. And we'll talk a little bit about that. The third one I'm just using for the sake of completion. This is a terrible way of influencing your community of practice. And it's basically pharmaceutical companies marketing their products disguised as research. But it's still good to know how the bad guys do it. So first we'll talk about quality improvement initiatives and how they can influence the community of practice. The one particular thing about quality improvement initiatives is that the learning and the change is happening during the research project, not after you publish it and read the conclusions, right? So this is one from our own unit about implementing family-centered care in the neonatal intensive care unit at JIPMER. And it was a quality improvement initiative. I'm using this particular one because it was published very recently. And I also wanted to, you can see that 3 of the names are highlighted. Those 3 are actually nurses in the unit. So when you see publications, you don't very often see the nurses' names, for example. Only actually 2 of them are consultants. The other consultants' names are not even here. And that's not because they did not help. It's because due importance has to be given to other team members. 2 of the others are residents, and 3 of the others are actually nurses who work in our unit. So you can see how participatory this is. If they had a hand in the authoring the manuscript, they actually were also working on the research project. So for those who are not familiar with quality improvement initiatives, basically what happens here is that you collect some baseline data about some outcome, let's say death among neonates, neonatal mortality of preterm babies. You collect some baseline data about some practice. In this case, you can see a mother doing what we call kangaroo mother care. So she's caring for the baby. There is actually a small preterm baby there between her breasts. The baby is so small, you may not be able to see her, but her yellow hat is visible, I believe. So it's actually a preterm baby inside the NICU. So what you see in the background, you can see a blue tubing going towards the baby. So this baby is actually on respiratory support, and the mother is actually managing the baby. So this is part of what we call family-centered care. So more and more involvement of the parents in the care of their babies. And this in general is a good thing, the involvement of the family in the care of the patient. It reduces the medicalization of death and disease. So I think it's in general a good idea, but it particularly is useful in neonatology. So what we do is we collect base, then introduce some interventions. In this case, it was family-centered care, which meant encouraging mothers, fathers, aunts, grandmothers, whoever is available to spend more time taking care of the baby. This actually reduces the workload on the nurses and increases the family's involvement. And because they are in the NICU taking care of the baby, they feel more satisfied also. They are aware. There are fewer miscommunications. They are aware of what is happening with the baby. So they don't, go back, and very often you read in the newspapers about parents complaining about what happened inside the NICU. That's because they are standing outside listening to others, and very often there are miscommunications, and they misunderstand what is going on inside the NICU. But when they are directly involved, these problems can be avoided. So now we introduce these interventions, and we can select these interventions based on evidence and our own experience also. And then we again look at the outcome while we are doing the intervention. We implement this for all patients in the unit, let's say family-centered care, or whoever actually meets a criteria, they actually go under family-centered care. While you are still tracking this outcome, maybe it is neonatal mortality or infection. And then after the intervention has been implemented in the unit, you continue to collect data for some more time and see if the effects are sustained. So this is how a quality improvement initiative works. You have baseline period, you have implementation of some interventions, and then a sustenance period where you actually see if it is still effective, or did the effect disappear soon as you stopped implementing or soon as you stopped working on it. Ideally, we want something that is sustained, a benefit that is sustained. So I just wanted to cover that in some detail to say how it works. And obviously for an intervention like this, the nurses are very important. The residents are the people who are always in the unit at the bedside. They are also important. And the faculty are the people who are usually guiding the project and troubleshooting when there are issues. But surprisingly, there was another group of people who were very helpful. And these were the peers. These were the other mothers who were in the unit. Some babies stay in the NICU for a month or 2 months, and these mothers have been in the unit for a very long period. And they actually know how the system works very well. And for example, if it is about expressing milk, they are able to guide other mothers voluntarily to express milk. How they actually can guide them through a lot of things, where to get medicines and other things. So they actually are an important source of involvement. So what you can see from this slide is the patient and the family are at the center of this whole thing. That is one important thing. The other thing is there is involvement by the whole team, and that team includes the parents, the other parents also. So there is a saying that it takes a village to bring up a child. You just don't need parents. You need also the barber who cuts the hair of the child, the teacher who teaches the child, and the whole place. So in research also very often it's like that. If it is teamwork, it is often much more effective. So a QI project naturally involves multiple stakeholders. It brings together multiple stakeholders with the family at the center of the whole intervention, or the community at the center of the intervention. So it has, by design, it actually influences all these people who are involved. So if the nurses are involved in implementing something like this, they are actually learning during the process, and they are seeing for themselves that this intervention actually works. So you don't need to have a separate educational component after doing the study to convince them, because they are part of it. So this is in many ways very participatory kind of research as far as the team members are concerned. So like I said, we have selected these processes based on evidence and experience. Multiple stakeholders are involved, including nurses, residents, and parents. The interventions tend to be more flexible, not like a randomized control trial. So if one particular kangaroo mother care chair for the mothers to sit on, if that is uncomfortable, we can always change it. If the mother is not available to do kangaroo mother care, we can get the father to do it or the aunt to do it. There is more flexibility in the interventions also, unlike many other study designs. New ideas are sometimes generated during the process. So the nurses may come up, for example, with a new way to fix a respiratory interface to the baby's face. And we often implement that either as a separate cycle in the same intervention, or in the next intervention, we may consider implementing that idea. And another peculiar thing about this kind of research is that research and the implementation of the process is simultaneous. But how does this help? So the idea is that this is, a rising tide. So there is a saying that a rising tide will lift all boats, not just your boat. So you may be the researcher, the primary investigator on paper, the principal investigator on paper, but the whole team actually benefits. They learn, they develop professionally, and change their views during the process. So there is a strong educational component. All stakeholders are involved. Most importantly, the patients, their families are involved in this kind of research project. So, and also the changes happen during the study. After that, the unit is a different place. Once you implement such kind of an intervention, like we had we had a QI project which was based on a human breast milk bank. And once you implement it, the place is changed forever. There is no going back to giving formula milk, because now you have human milk available with a human milk bank just outside the unit. So everything changes. The practice changes during the study. The participants change. The practitioners change. This really is research in some ways in its best form, because you have managed to translate the evidence into practice at one go during the research project itself. So how does this compare to, for example, a randomized control trial? So this is a randomized control trial from our own unit. And Dr. Bhatt also was involved in this. So this was published just earlier this year. So this was a small randomized control trial of a particular intervention. I'm not trying to say that this is a bad study, or like my own research is bad. But what I'm trying to say is this actually influences a much smaller group of people. There are people who are interested in this. But the involvement of the nurses and the residents in this particular study is much less than you would get with a quality improvement project. This is not really hands-on learning for them. At the end of the study, you come to a conclusion whether this intervention is effective or not effective. And if it is effective, then you have to find ways to implement this in practice. So this is a very stepwise system, although it generates very strong evidence. So the advantage of randomized control trial, and the reason it is on the top of the evidence pyramid, is that it is a very strong research design, provides very strong evidence for an intervention, but it can only be applied to specific circumstances and specific research questions. And implementation is not guaranteed, even if you show the intervention to be effective, because the community still has to accept it. And you have to work on disseminating this knowledge to the community and convincing them that this is a good thing. This particular intervention actually was not effective. But that does not mean all randomized control trials work like that. Some do change practice during its implementation also. So one example is this large multicentric study from 5 NICUs in India, and 1 in India and 4 in Africa. That was published just a few months ago in New England Journal of Medicine, just 3 months ago. So this was again about kangaroo mother care and survival of infants with low birth weight. This was a very effective intervention in reducing neonatal infections and neonatal deaths, where actually mothers were caring for babies who were very small, 1 to 1.7 kilo, 1.8 kilos. So really fairly small babies. And these mothers had beds in what is called a mother NICU, mother NICU. The mothers had beds, the babies had beds, and most of the time the babies were on the mother's chest. Of course, this was a randomized control trial, and this was only half the mothers were doing that extensive kangaroo mother care. The other half were just getting standard treatment. But still, it influenced practice while it was going on because the whole team knew about it and they could see what was being done. So it's not that randomized control trials cannot influence practice, it's just generally more difficult. The second, so that was about quality improvement initiatives. That is an excellent way if you are in clinical medicine, but also in other areas actually, of doing research and influencing your community of practice to change their behavior at the same time. That is still more in the quantitative research domain. You can have some qualitative components to it also. But participatory action research predominantly is in the qualitative research domain. And so basically here the community is in front and center of the research process. So I'll give you a minute to read this, the beginning of an interview. This is from, I actually don't exactly know from which of Mr. Rahman's publications this is. I think it is from a 1993 book of his, because I came across this in another publication. So obviously this is a conversation with a tribal person. So this was a few decades ago, actually, in a place near Mumbai, a very tribal area where actually the tribals were really oppressed and actually were practically in slavery because they were, economically indebted to money lenders. So the Saukar is actually a money lender. So, but you can see that this, person who is practically illiterate, who is in debt, practically working like a slave, still has the perspective that the moneylender controls him because he has knowledge, and that knowledge is very important in working towards equality. Actually, there was a whole these people actually rose up against the moneylenders. This was a Bhumi Sena, not the other Bhumi Sena. There was a violent Bhumi Sena also. This is a different one. And their experience in raising up their own community was so influential that it actually influenced much later. It influenced an intervention in Sri Lanka on similar lines called the Change Agents Program. So basically what happened is during the process of this conversation and research itself, they were able to increase the awareness of the people. And the people actually took over the leadership of addressing the issues that were identified during the research process. So I'll give you a specific example. This was about a participatory research study from Kerala in district called Wayanad. There are many tribes. There is a large tribal population there, and they are also very marginalized. Most of them work as manual laborers, and if they don't work for a day, basically they starve. That's the kind of poverty they live in. And unlike the rest of Kerala, which is well known for its healthcare system, these people actually have very poor access to health. So it was interesting, also very relevant to find out why that was happening and what could be done about it. But you have to treat them respectfully. These were people who were originally owners of the land, but now had been enslaved for generations and pushed out of their own lands, most living in abject poverty and alcohol addicted and smokers and all that. And this was actually done very respectfully. Some foreign agencies were also involved from Canada, but they actually conducted the whole research very respectfully. The way they went about it is first identifying the problems. And this was not done by the researchers. They were allowing people to talk. Basically, they approached the community through the leaders, the movers, and they actually spoke first, and then they gradually got to speak to the other people. So the community was voicing their own problems, and the community was identifying the underlying issues. And through this process, they were identifying what the problems were, how they could solve it. Potential solutions were also identified with the help of the community itself. And ultimately, the idea is that the community takes over leadership role in working towards these solutions. So this is very much again research, and literally this is a community at large here we are talking about, where the community takes a role in research, right? This is not just the research community of practice that we are talking about, but also the community of tribals. So very participatory. And here again, there is no question of trying to implement a solution. Implementing a solution sounds very patriarchal, like we are forcing it down somebody else's throats. But here the people are taking things into their own hands and actually working towards solutions. This actually is very inspiring research in some ways because this is truly beneficial to people. This is not being pushed by any pharma company. So in participatory action research, the focus is on participation. For individuals, this means engaging in and contributing to the practice of the communities. For the communities, it means refining their practice and ensuring new generations of members. And for organization, what it means is sustaining these communities of practice. So the third thing that I thought I'll just briefly touch upon is seeding trials. So because we still get approached by companies for doing studies, for example, and not all of them are genuinely interested in finding out if their device works or if their product works. We generally try to stay away from it. There is nothing wrong in doing a sponsored clinical trial, but it can be problematic depending on who you're dealing with. So this is because whenever there is a good way of implementing things, there is also a bad way of using that knowledge to implement things. So, but we can learn from them. We can learn from the bad guys. So seeding trials are a particularly bad way of doing research. And this is an example of a trial. This actually, you are all familiar with Pfizer, one of the largest pharmaceutical companies in the world, and now with their vaccine and everything, they are a multi-billion dollar industry, obviously. And this trial took place a few decades ago. This was about gabapentin, and it was, it was cloaked as a phase 4 clinical trial. But one of the first problems with the trial was they recruited 772 investigators across the United States. So you can already see what they're doing. This is participatory research. They actually know that if I'm involved in the study of a particular drug, I'm much more likely to remember its name and much more likely to prescribe it. I'm much more likely to talk about it in my meetings to my colleagues. So the more people, the more influential doctors they recruit in the study, the better. So this has happened in India also, where, for example, a skincare company trying to recruit people from 40 different institutions for their study of their product. They could have actually done it in 1 or 2 centers. But if you involve more opinion leaders in your study, their brand recognition will be stronger. By word of mouth, the knowledge about the drug spreads. So this is what is called a seeding trial. And it is highly unethical. Actually, Pfizer was taken to court for this and they lost. They had to settle and they had to pay out millions in settlements. Obviously, they hired a huge number of investigators who were mostly inexperienced, some inexperienced also. And the sales representatives were actually collecting the individual subject data also. Highly unethical practices were going on. So I take a rather skeptical view of drug companies, although their vaccines may be effective and the drugs may also be effective, but their methods are not always correct. Although this was not a seeding trial in the traditional sense, you all know about post-it notes now, and we all use them. When they started using it, when they started marketing it, one of the things they did was they mailed it. They didn't mail it to the bosses. They mailed it to the secretaries of some of the most important people in the United States across the country, and they mailed it with asking them for suggestions for possible uses. So basically getting them involved, getting them to do things. And this kind of marketing was not common at that stage and helped a lot in popularizing post-it notes. And you know how popular they are nowadays. So this is used across the industry, seeding trials. And this is nowadays, I would think this would be called viral marketing or something like that. But originally started off as a seeding trial. So to summarize, the community of practice you can think of as your team in practice. And this, you may be at any given time, maybe you may be part of multiple teams. As students, you will be part of one team. As professionals, you may be part of another team. I'm still learning some things, so I think of myself as a student also in some ways. So that is a separate team. And at work, you have different research teams, for example. So you are usually a participant in multiple communities of practice. You have shared interests and goals, and you develop knowledge, methods, and tools, the team. And when I say you, I mean the team, not you as an individual. And they also increase their relationships, strengthen their relationships through discussion, mutual learning. And this is the most exciting part of research as you get older. Initially, you are more worried about how research is done. You are trying to learn research methodology. Later, you are more concerned about why research is done and why I'm interested in this question and why I should spend part of my life working on this particular research. Who am I working with? Is it interesting to me and the team? Specifically, the research team. So these are some specific terminologies used. The same things I mentioned in the previous slide. But the shared interest or goals, we call it the domain. The relationships form the community. And the knowledge, methods, and tools that we develop form the practice. On a practical note, what this means is if you have to influence your own team, if your own, and this, when I say team, it doesn't mean it's at the local level. It doesn't mean when my team may not be just the team in the NICU. For some communities of practice, this may be at a national level, this may be at an international level. But the idea, at least if you're a researcher, is that the whole team for that particular community of practice should share an interest and should share the need for that particular research issue. They should be passionate about it. So unless the team is passionate about it, that team is not going to be particularly successful. We live in a democratic setup now, and the old hierarchical models don't work very well. So decision making should be shared, and you should be more flexible about incorporating others' suggestions, especially when you are working with the people who may be more inhibited to contribute, like nurses or medical students who feel the inhibition more. You actually have to be more proactive in eliciting opinions and implementing that as part of the decisions. In between, you may have to stop and think about whether I'm doing this right, and ask others also sometimes if this is going in the right direction. And finally, like I was showing about the publication, give credit where credit is due. In almost all our presentations involving research in the NICU, there are nurses' photographs, the residents' photographs, because they are actually very important in actually conducting the research project. And they are the ground level staff. They are the, you may have developed an idea on your own, but they are the ones actually implementing the research project. So give credit. I think that's pretty much all I have to say. Thank you. So if there are questions, I think there are a few.
Thank
Shall
you,
I take
Vishal.
questions now, ma'am?
Yeah, just 1 second. I'll help you with the questions.
I think
Ah.
Dr. Bhatt has posted a
Yeah.
question. Why do you think quality improvement projects have taken time to get started? Yeah, thank you, sir. So this is actually has been a problem because one, it has its own terminology and jargon involved. And it is a systematic way of doing things. It is not that you think something is nice and you start doing it. That is not quality improvement. There is a systematic way of doing it. There is some technical jargon involved. This came from the industry again. This came from, most of the techniques came from Toyota and the car industry. So the way they phrased it is somewhat different from the way we would have developed the terminology. So it can sometimes be a little intimidating. So that was one problem. The second problem was everybody thought this is quality improvement. So how is this really research? So at one stage, it was not even possible to publish it, or it would be very difficult to publish these things. But now, for example, there is a British Medical Journal group has a dedicated journal for quality and safety. There are other journals also. A few years ago, Indian Pediatrics had a full special edition on quality improvement studies, about 12 or 13 studies in it, published in it, including some from ours. So nowadays, people every month, pediatrics, the American Academy of Pediatrics journal publishes at least 1 or 2 QI studies. So things have changed now. And although it has taken time, nowadays it's much more easy to do quality improvement projects and get your results published. The other problem with QI projects is that they are very context specific. The interventions that work in my NICU may not work in other NICU. So the external validity, unlike a drug which may work in multiple populations, these interventions that are effective in our setting may not be effective. So the interest may vary. So that's another reason publications are a little hesitant.
And,
okay, so is there anything else?
But sir, did it answer your
Sir,
question?
thank you, sir.
See, these quality improvement projects are more cost effective, cheaper. But suppose
yes,
you
sir.
say,
Most of them we don't ask for any funding, but some can be depending on the intervention. Some may cost money also, like a human milk bank. If you're doing it as a QI project, it will cost money. But yeah, many of them actually that is partly the lack of interest from industry also. Because if it is free, Pfizer is not making any money and nobody else is making any money. So nobody else is interested in pushing it. You can't show funding as part of your CV also. You don't get any funding for it. You're doing it for free. But patients usually benefit much more. So you're right.
There's one reference in the chat box from Dr. Mahadevan. He has said that he really enjoyed your reference to Racing Tide and also the term viral marketing. The only thing is that that Rising Tide, what I thought also was very nice, the way you put it across. Like especially when you try to compare what RCTs do and what quality improvement projects do. When you are immersed in that, even if it is a small thing, if it is yours, then it makes a lot of difference to people. I think that is the major difference what immersive experience what people get out of it. Actually, when we train residents, there are only two things which we find it very difficult to teach. Everybody learns knowledge. Sooner or later, everybody picks up all the procedural skills, right? And if they are going to practice, they kind of become okay with communications. At least they become manageable and all. But the most difficult thing is to teach is what is system-based practice, right? How do you adapt what your system is, and how can you think about improving the system? That is the most important or most difficult aspect to teach in any of the residency programs. And also, how do you improve upon and assimilate knowledge as it comes? Look for evidence and incorporate it into your practice. So if it's your own evidence, and then it becomes much more this thing. But one nice thing I found in your talk is that you were talking about getting due credit to your residents, nurses. I think that was very appreciable, the way you had put it. We are all in COVID time, so we keep talking about vaccines and immunity. So they have found that for herd immunity, we need 80%. No? So if we can immunize 80% of our residents and nurses into thinking about quality, then I think our work is very much done. There is one very nice quote from Kumari Sandhya. She says, "Thank you, sir, for such a wonderful session. It was really thought-provoking." And also from
Thank you, sir.
Mahadevan, sir.
Yeah.
One's own experience is one's truth, and that is why community of practice is implementable. Okay.
That is correct, sir. Thank you, sir.
Have you actually noticed any organizational change or change in your unit because that you have done so many of these quality initiatives in your own unit, and you said that people got involved in this process? Did it change the culture of your unit in any way?
Oh, yeah, absolutely, ma'am. So an ICU in particular operates like a family. And actually, and that at a personal level also, I can tell you that when I walk in, I don't feel like I'm out of place every day. I mean, there may be issues at home, on the road, but when you walk into the NICU, it still feels like home and you're always in a good mood. And that the reason partly is that the whole team operates in very close coordination. The side benefits are that the nurses are often more proactive. If somebody, even another consultant from another department walks in and without washing hands, they will offer hand rub, or they may ask them. They feel empowered to do what they should be doing in the first place. And the hierarchy is very loose, so they feel easy to approach the head of the department or me to with their problems, even minor issues like problems with consumables or drugs. So the work culture is very different. Traditionally, we have been one of the leaders in JIPMER, and when it comes to hand hygiene and things like that. That has become stronger now. We generally win the trophy every year for best ward or best hand hygiene audit and things like that. So the whole team takes pride in it, in their work.
Has it translated into patient satisfaction outcomes or patient outcomes? How much it has changed? Have you measured this?
We haven't really measured it, ma'am. It's still not, I mean, there is always room for improvement, and that's one of the things about QI. There is definitely room for improvement when it comes to patient satisfaction, because there are also a lot of limitations, especially in a public sector unit like ours, which is very overcrowded. For example, we often have to refuse patients because we don't have beds. Mothers are not always happy because there are two babies in a warmer sometimes. So there are some issues that are beyond our control. But the whole idea about QI is that you work within your constraints and try to improve quality. Things that are beyond your control, you just have to ignore.
Okay, there's a very pertinent question, one Dr. Tyagarajan. He's asking about what is the role of accreditation process in influencing community of practice.
Yeah, so accreditation process is basically the stick, sir. So there is a carrot and stick approach. What I was talking about is the carrot, and what you're talking about is the stick. So if the accreditation is required, you have to have this, and this. So it would be good if we are able to implement the same thing, even if we didn't want accreditation. Right. So these are the best. What accreditation agencies will set out are a set of criteria, which are, for example, the best practices for a lab. So if the lab can implement it and then ask for accreditation, that is better, because they think they are already at that level where they deserve accreditation. But accreditation is one way of implementing quality, but it is top down. It is not participatory, but it works. I mean, there is always some push and pull involved.
Thank you. But sir, your comments, feedback, reactions.
I think the talk was interesting. You were asked about the quality improvement or community of practice. How does it help the population? See, the moment they participate, they learn the technique. Like he was talking about hand hygiene or breastfeeding. This they get involved in the sense that practice continues. So whatever you tell them, people don't understand unless they participate and find that it is useful. They do not practice. So that's very important. Even like milk bank or educating the mothers on breastfeeding, it has done a very good thing for the community because the number of mothers breastfeeding at 6 months have increased dramatically in a sense. So you make the mother to do, she understands. Suppose you tell you breastfeed, she listens, but she doesn't really actively do it. Similarly, the importance of hand hygiene, if you tell how it prevents infection, she will just listen, she will forget. But day to day, she does practice, she understands. And then it goes to the practice. I think that is what is important. This quality improvement projects, there is not much money. I think that is one reason why people are not interested. Suppose you tell a drug company or somebody to sponsor some antibiotics or something, there are many people who will sponsor because there is money after your practice. Whereas if you want to prevent infection, they are not interested because unless there is infection, their antibiotic will not move. So it is like that. People are looking at the outcome, whereas we are looking at the patient's outcome and the improvement of the community. I think that is what more important in the long run.
And other thing to take away from this talk is that you need to generate evidence in your own context. You can't take what evidence is applicable in Canada or Australia, even though it must be a well constructed RCT, but still trying to apply it in your own practice becomes much more difficult because of that. So that is another lesson I think we take from this particular talk. Thank you, Dr. Nishad, for a
Thank you.
very interesting and engaging talk. When we actually thought about this, we started about asking how we can generate evidence. Does it influence how the way they look at the specialty and they practice? And then we talked about this particular topic. So initially, when we were thinking about that topic, we were thinking whether we will have enough to talk on that particular thing. You made it very interesting. Actually,
Thank
following
you.
this, we have another talk. Very, very nice talk. Now, week after this, not next week. On 10th of September, we have a community medicine based person from Chennai who is going to talk to us as how we can generate evidence from ethnographic and qualitative studies to influence policy decisions. I think he is involved in this Government of Tamil Nadu projects. So he is going to, Dr. Vijay Gopichandran, he is going to talk to us about how evidence we can generate from ethnographic studies to influence policy. And that was this. And I thank Dr. Nishad for a very wonderful lecture on
Thank you,
behalf of
sir.
the scientific.
Thank you for inviting me.
Yeah, on behalf of the
And yeah,
scientific.
thankful to you for talking.
Yeah, and for next week, we have another interesting talk. We have former professor of anesthesia from JIPMER and former dean of MGMCRI, Dr. M. Ravishankar, who is currently the e-learning director at SBV. He is going to talk to us about the concept of eco-friendly hospitals and green OT. Is there evidence to support these fashion trends or the recent fads in the hospitals? And how we can do this. So that is what is the talk for next week. Eco-friendly hospitals and green OTs. So what is the evidence? So with this, I would like to close this session. Thank you very much for participating. We hope to see you again next week on Friday afternoon 3 o'clock. So till then, stay safe and bye-bye.
Bye.